Good afternoon, everyone. Good morning and good evening to those where it's morning and it's afternoon. Welcome to today's webinar, which is being hosted by the Global Health Network. My name is Dr. Oscar Tapera. I'm from Zimbabwe, and I'm going to be your chair today. The topic of today is evaluating the global impact of COVID-19 on child health and births. And this webinar is divided into two talks, one which is going to be presented by iPOP, the iPOP study, which gives an international perspective, followed by the second talk, which will be presented by Dr. May from Brazil, which will give a more localized and a contextual perspective of the impact of COVID-19. Before I introduce the speakers for the first talk, allow me to run a few housekeeping issues for this webinar. Firstly, please kindly note that this webinar is being recorded and will obviously be shared by the Global Health Network through the platform. And please, if you want to introduce yourself, kindly use the chat. I'm sure Adam has already indicated that. If you also have questions, please use the Q&A functions that are on your panel. Due to the high number of participants in this kind of workshops and webinars, please kindly turn off your camera and also your microphone to ensure that we have good quality, as this is also being live streamed, and we would also want to ensure we have adequate bandwidth for all of us to be able to hear the presenters. And if there's any challenges, please also use the Adam is on standby to kindly assist on any technical issues. So colleagues, allow me to introduce our first speakers for the first session. For the first session, I would like to introduce Dr. Megan Azad. Dr. Megan Azad is a professor of pediatrics and child health at the University of Manitoba in Canada. Her research is focused on the role of infant nutrition and the microbiome in child growth, development, and resilience. She is also going to be co-presenting with Dr. Kofi Amega, who is a senior lecturer at the University of Cape Coast in Ghana, and whose work focuses or interfaces on nutritional and environmental determinants of adverse perinatal, maternal, and cardiovascular health outcomes in Ghana. The third speaker will be Dr. Begner, who is a senior research fellow at the Murdoch Children's Research Institute in Australia. And his research is based on international data linkages relating to premature birth outcomes, and also infant and child health. And finally, Dr. Clara Calvert, who is the Chancellor's Fellow at the Usher Institute, the University of Edinburgh, and Assistant Professor at the London School of Hygiene and Tropical Medicine. And her research focuses on on data quality assessment and also statistical analysis. And colleagues, with this, I would like to welcome the first Dr. Azad's team to present their talk. Over to you, Dr. Azad, and your team. Thank you.
Good morning, good afternoon, or good evening, wherever you are joining us from in the world. It's a pleasure to be here with some of my colleagues from the iPOP study to present to you some of our work over the past year during the pandemic. So we're going to speak to you about studying perinatal health internationally during the pandemic. And maybe a little more shorter and fun title would be the iPOP study, the story, the study, the stuff, and the spirit. So speaking with me, joining me today for the webinar are Dave Bergner, Kofi Amega, and Clara Calvert, who you just heard introduced in the introduction section. Natalie won't be able to join us this morning. And actually, we're here on behalf of the larger co-leads of the iPOP study pictured here. One of the great things, as you'll hear, is that we're spread around the world, meaning it's not the best time zone for some of us. So we split up the assignments and speaking duties. The iPOP study is actually a collaboration of over 160 collaborators from 41 countries, including 21 low and middle income countries, which you can see pictured here on this world map. So it's really a true team effort of researchers and healthcare providers around the world. And it's our pleasure to be here on behalf of the team to speak to you this morning. So beginning with the story. So how did the iPOP study get started? So really it was inspired by these reports fairly early in the pandemic that there had been a change in the rate of preterm births and potentially a change for the positive. So fewer preterm births. This was reported in a few high-income countries, just as anecdotal evidence. So we wondered as epidemiologists in the neonatal space if this was really true, and if so, what was the reason? But shortly after, we were also concerned because there were reports of increased rates of stillbirth during the same period, and these were more often coming from low and middle income settings. So, you know, this could either be a silver lining of the pandemic if there were fewer preterm births, and that would be important to understand, or it could be a real cause for concern. And so we wanted to get to the bottom of this. And our questions were, firstly, is this really happening everywhere? So was this just an anecdote? Was it kind of a blip in the data? Or was it a true change in these important perinatal outcomes? And if it was a true change, then we wanted to know the reason. Was there something we could learn from this natural experiment of the pandemic that would help us respond to the pandemic globally and future pandemics, but also understand the underlying biology of preterm birth and stillbirth? And then finally, a really important question, are all pregnant people being affected in the same way? So is this a consistent pattern around the world, or are the effects different in different settings? So really, I'm going to focus on that first question because we have to answer it before we can get on to the other two. And so in terms of the timeline for this study, which is pretty fun to look back on, it was a whirlwind truly in terms of research. And so these were some of the milestones. So we first noticed those anecdotal reports of changes in preterm birth in June of 2020. And so Marilee Brockway is one of the other co-leads on the study, and you can see our Twitter conversation here. You know, is this really happening? If it is it actually a result of increased stillbirths or miscarriages, or is it a good thing? So we said, well, if nobody's done a study yet, maybe we should be the ones to do it. And so in about a month, we put together a large group of people who were interested. We called our first meeting. You can see here, it was before we had a logo. We reached out to Dave Bergner as our first point of contact. You'll hear from him later today in the presentation. And we had about 40 or 50 people join this first kickoff meeting. And so they were from around the world, and they were clearly interested in answering these same questions like we were. And so we opened up a Slack workspace and had people starting to join and start a conversation around how to answer these questions. In the next couple of months, we submitted 5 grants. We presented 5 abstracts about our concept and proposal at different conferences to gain even more interest. We published a letter in the Lancet about our plans to form a global consortium to really address these questions in a rigorous way. And so by November, we had our 100th member join the iPOP group. So it was pretty fast. Many of us on the study do international research in our pre-pandemic lives, and we'd never experienced anything like this in terms of rapid growth. So it was really exciting to be a part of. Moving to 2021, we started collecting data and analyzing. So in January, we were able to distribute over 80,000 pounds to 21 of our collaborators to support them in collecting data. So there was a wide range in terms of people who had essentially free access to administrative data and could provide it to us at no cost, but others, especially in low middle income settings, required financial support to collect this information. So we're able to do that quite quickly. We published our protocol online in February, and it's freely available on Welcome Open Research. You can see by the long list of authors there that it was, again, a large team effort. And by March, we were executing our data sharing agreements and having our first data sets be submitted. So we were able to start analysis in April, and we're now finalizing our results. So they're not quite ready for sharing. You won't see the results today, but you can stay tuned for those pretty soon. So that's the story of how we got started and put our team together. In terms of the study and how we're doing that, I'm going to pass it over to Clara.
Thanks, Megan. So I'm going to provide a bit more detail about the analytical approach and data available to address the research question highlighted earlier by Megan. So was there really a reduction in preterm births as a result of lockdown? So what methods have we used to approach this research question? Data that were provided for this analysis were aggregate monthly numbers of births categorized by gestational age at birth from January 2015 to at least the end of July 2020. And these data were provided at either the national, regional, or facility level, depending on data availability within different countries. Each collaborator has provided these data according to a standardized template and have uploaded their data into the SAIL data bank, which is a data safe haven in which we've conducted the main analysis. So our exposure, we have defined this within each country by the month of the country's initial lockdown, which was defined by the date at which the Oxford Stringency Index first exceeded 50. Months before this date have been categorized as pre-lockdown, and months after this date have been categorized as post-lockdown. And in our analysis, we've looked at the impact of lockdown on our outcomes at 5 main time points. So the month of lockdown, as well as months 1, 2, 3, and 4 after lockdown. Our main outcomes are preterm births, which are births at less than 37 weeks of gestation, divided by the total number of births. And the stillbirth rate, which is the number of stillbirths, also divided by the total number of births. For the analytical approach, we have conducted interrupted time series analysis for all national and regional level data sets to assess the impact of lockdown on our outcomes for each country separately. And we're then using random effects meta-analysis to combine the odds ratios across all the countries and have stratified that by the time since lockdown. We've used a slightly modified but very similar approach for the facility level data. Sorry, next slide. So far, we've analysed national level data provided by 12 countries, which is shown in purple here, regional level data from 1 country, Denmark, and facility level data from 9 countries is shown in yellow. Across the national level data sets, the average preterm birth rates vary between 5% and 12%, and the stillbirth rates vary between 2 stillbirths per 1,000 births to 12 stillbirths per 1,000. Okay, next slide, please. And here is a little bit more information about each of the data sets we've analysed so far. We have 13 population level data sets providing data on over 24 million births. These data sets are predominantly from high-income countries, with 2 from upper middle-income countries. And as we can see from this table, many of these births, so over 60 million, are from Brazil alone. We also have 25 institutional, so facility level data sets from 9 countries, providing data on over 500,000 births. In these institutional level data, we have more representation from across different country income levels with the inclusion of low and low and middle income settings. Next slide, please. We have had to unfortunately exclude a number of data sets from the analysis, and these have been exclusively institutional level data sets. There have been a range of exclusion reasons, as shown here on this slide, from having very small numbers of births leading to very unstable estimates, to having inadequate time periods covered by the data, to data quality issues leading to some implausible distributions of preterm birth rates. So alongside being able to draw some important conclusions around the impact of lockdown on preterm births, we hope to be able to draw up some recommendations on ensuring data availability to address similar research questions in the future. And so now I'm going to pass back to Megan, who will talk through in a bit more detail about the structure of the project.
Great, thank you, Clara. So in the next session, I'll tell you a little bit about the logistics of the study, or the stuff that we needed to carry off this large international project. So this is an overview of our study structure. So you saw earlier our leadership core involving 6 people with different expertise, ranging from mechanistic investigations with David Bergner, who you'll hear from later, maternal fetal medicine, as well as management and operations. So Natalie Rodriguez would have been delivering this section if she was able to join us. She's a critical part of the team, bringing expertise in operating large studies. So we have some working groups involving other members of the network. We have, importantly, a low middle income country working group, and you'll hear from Kofi in a moment about that. And we also have a knowledge user working group, which has been really important to ensure that our study questions and operations are addressing the most urgent needs of our stakeholder groups. So it's important to think not just about the research and the questions and the methods, but the underlying infrastructure. So it's not enough to dream up the questions. You need these underlying elements to make it work, especially in a large international consortium. So we have a novel idea, we have a team together, but we also need tools and resources. And so I'll mention a few words about that. Some of the really important tools, having a global research team operating during a pandemic entirely remotely, have been technology platforms. So we're all on Zoom today. We use this platform amongst our team to meet regularly, both in small and large groups. We've been using Google Drive as a means to share documents. When you have dozens of authors on a protocol, for example, you don't want emails flying around with Word documents. So that's been really useful to have everyone able to contribute in a timely manner. I mentioned that we use Slack as our main platform of communication. So you can see a snapshot here. We have channels set up to address different elements of the study, from discussing relevant literature to drafting documents and answering questions about ethics submissions, for example. And we use World Time Buddy, a little app for figuring out what time it is all around the world for our different members when scheduling meetings. We also have, and this is available on the website, ipopstudy.com, if you're interested in reading in more detail, a guiding principles document. And so this is signed by all iPOP collaborators before we welcome them into the Slack workspace. And so it addresses things like authorship and communication and confidentiality of data. So that was really important to develop early in the study. Data contribution agreements. So for those providing actual data to the study, it was important to have agreements in place. Data submission templates. So having templates available so that everyone is submitting their data in the same format was crucial for being able to then analyze it all together in a consistent way. Some countries and institutions required ethics approval to submit this data. Others didn't, because it's actually just aggregate administrative data that we're analyzing in the first instance, but that was important to be able to address and support our data providers on. We held drop-in sessions over Zoom for people to ask questions and get answers in real time. And then having expertise in things like legal and administration and HR and project management has been really important to having the study work smoothly. So with all those tools and resources in place, we were able to really accelerate the timescale of this project. So I mentioned earlier on that it happened really quickly compared to projects that many of us are used to working on. So some examples here: in kind of the average project, it might take 150 days to get a guiding principles document prepared and accepted and onboard our members, and we were able to do that in 3 months. So it's been a rapid response, and that was really important during a timely event like the pandemic. So I briefly mentioned our patient and knowledge user group, and so that's been really important. We hold meetings with them periodically. We engage them very early in the study to make sure that our questions were meaningful to them. And you know, some studies tend to engage their stakeholders at the end as an exercise in knowledge translation, but we were really careful to involve them from the beginning so that we could ensure their involvement all the way through. So I'm going to now pass over to Kofi to speak about our low middle income participating countries.
Okay. Yeah, hello. Yeah, so it's very refreshing to be here today and to be joined by a large group of people, and also it's very nice to be part of this global initiative. And often some of these global studies, you realize that countries from low and middle income countries are cut off, but in fact this is very global in nature. So we joined the iPOP study, and also we earned some funding to be able to contribute some data towards the initiative. So what we did basically is that manually we collected data from 11 facilities, and this covers 6 metropolitan areas of Ghana, including Accra and Kumasi, which are the 2 major metropolitan areas. And we did this collection by trying to respect the northern and then southern divide of the country. But as you know, we have issues here in low and middle income countries, major issues when it comes to accessing data. Also data quality issues, and also some of the bureaucracies that are involved in trying to access these data. So, you know, all the data that we have in the hospitals are not digitized. I mean, most of the data, I think if you take immunization out, virtually all the data on perinatal health are not digitized. I mean, I'm speaking from Ghana, but I think this cuts across most of the low and middle income countries. So we had to manually collect these data from the facilities. And again, you and I know what the problems are going to be. Some of the books are missing, some of the pages are torn. So in fact, it was a very Herculean task to do that. And there is also a lot of missing data issues. Is there a next slide, or this is the only slide, Megan?
This is the only slide, I think.
This is the only slide, yeah, so let's stay there. So, I mean, I think one of the things we want to do with this iPOP study is also to make some recommendations, but I must indicate that the data that we got from Ghana looks very promising. And in fact, within the group, we've been thinking about even using the Ghanaian data to test some of our analytical methods. But as Megan indicated in her earlier submission, is that we also need to try and proffer some solutions or recommendations for improving perinatal health in low and middle income countries. And I think one of the things that we need to look out for is that, I mean, increasingly government needs to know that data is what drives policy. Most of the policies that are initiated in our settings are not informed by the local evidence, because one, we don't have the researchers who are acting on it. And also we don't have the resources to tackle those local problems and generate the local evidence to inform these policies. So you realize that largely they are based on anecdotal and also some of these evidence that is coming from Europe and North America. It doesn't necessarily even inspire confidence in government to even invest in the problems. So I think that is one thing that we need to look at, especially when we are on a global health network. I think it's something that we need to also look at, and also try to strengthen our health system such that we'll be able to digitize all these data that are in the health facilities, and then they can become very beneficial to some of these global health initiatives as we have started. So briefly, I think that is my contribution to the presentation today. And thank you, Megan, for the opportunity, and also Global Health Initiative.
Thank you, Kofi. It's been fantastic having you involved in our regular analysis team meetings and bringing that perspective from the low middle income settings, because it is so different from some of the others. So in the last few moments, I'm going to pass over to Dr. Dave Bergner to speak about the spirit of the iPOP study and some of the approaches that we've taken.
Yeah, thanks, Megan. Just with an eye on the clock from a wintry late night Melbourne. Just some reflections very briefly. And we realized, I think for everyone, 2020 was a complete blur. And I think looking back, none of us would have been able to do this on our own. This was really a team effort. And I think, you know, I'm not sure we would do it again, but it was just a whirlwind. And I think the fact that we had a big multidisciplinary team, we realized early on we needed a broad range of expertise, and we were able to draw that together very quickly has made us a success. Our core philosophies and in the chat are our guiding principles. Those have been absolutely key. You can talk about those in the abstract, but actually getting everyone to sign off on those, which was very easily done, has been key. And the stakeholder engagement has also been key. And those have been really genuine. And the next slide, Megan. So funding, as always, it was a juggle deciding whether we spent 3 months trying to get funding or getting on with it. And given the nature of the pandemic, we got on with it and tried to do those things at once. There were a number of issues that we'd come across. Particularly, one thing was with our funding partners and with some of the people who assisted us, we came from different backgrounds. So sometimes we didn't really necessarily, we had to struggle to speak the same language in terms of our academic scientific approach versus the process-driven approach. But we found common ground very readily, and Kofi's covered some of the LMIC considerations. We made that an absolute priority from the start, and it's not for me to say whether that's been a success, but I think it's we've tried very much to make this a very genuine and inclusive collaboration. And I'll leave it there because I'm aware of the time. Thank you.
Great, thanks, Dave. And thank you to the Global Health Network for having us today speak at your seminar series. We're looking forward to the next talk, and I think there'll be some time at the end of the session for questions of both of us. So for now, I'll just acknowledge our, again, very large team of iPOP collaborators, and thank you all for your attention. We'll be here and we'll keep an eye on the chat for the questions as well.
Colleagues, thank you so much for your presentation. We'll move over to the next presentation, and I'm going to introduce the speaker for talk 2. And our speaker is Dr. Maria May. Dr. Maria May is a neonatologist from the National Institute of Women, Children, and Adolescent Health, Fernandes Figueira Institute, and she's going to be presenting on their study in Brazil. Over to you, Dr. Mayo.
Hello, thank you for this opportunity of sharing our results. And I want to share my screen here. And okay, it's here. Are you seeing it?
Dr. Mayo, we can see your presentation. Thank you.
Okay, now let's start then. Thank you for this opportunity. Our study was on the repercussions of social isolation due to COVID-19 on neonatal ICU former patients. This study was financed by the Programa Inova from the Oswaldo Cruz Foundation. COVID-19 was a great burden all over the world. Now we have vaccines, we have more knowledge about the pathophysiology of this disease, so we can have treatment and to help the patients. But when it started, we knew nothing about this. We only knew that it was very contagious and life-threatening. So the government had to underwent very strict measures to control the dissemination. So people are asked to remain at home. In our country, we didn't really have a lockdown, but we have an interruption of the normal living. And the people, this isolation, this confinement at home, it can have negative effects, both in physical and mental health of person and their children. The schools and the nurseries were closed. They are open right now. And the children lost contact with their teachers, lost contact with their classmates, and they lost contact with other members of the family, like grandparents, cousins, and even the friends in the neighborhoods. For the children under therapy, it was worse because they had their appointments and therapies interrupted because the clinics and the hospital had to decrease the number of patients being attended. Moreover, this prolonged confinement brought some disruptions in the family dynamics because the parents had to work at home, and some lost their jobs, and some families they are lost because of the infection of COVID-19. In this case of this pandemic, it's worse because when we have a disaster, we can share, the people who are affected can share their sorrows, their losses, but here, in the pandemic, this pandemic, no, we have to be isolated and we have to be separated for your people you love. The positive effects of this confinement, if you can say so, is that the families being together, they can promote more intervention, they can stimulate group games and family activities that would be a positive effect inside the family. But what about children who had been in an ICU, either for prematurity or other life-threatening conditions? These children, when they are discharged from hospital, they are followed to check for development abnormalities so that we can give them an intervention to help them. But all this was discontinued. So the proposal of this study was to understand the repercussions of the social isolation in children at risk for neurodevelopment abnormalities. So the objectives of our study was to evaluate the nutrition status of these children, motor development, behavior and emotional development, and the strategies the family undertook to cope with these stressful situations. For this, we did a cross-section study enrolling 3 public hospitals in Rio de Janeiro, Instituto Fernando Figueira from Oswaldo Cruz Foundation, Hospital Pedro Ernesto, the University of the State of Rio de Janeiro, and Hospital Gafreguini from the University Unirio. All the ethical committees of all these 3 institutions approved this study. The children are included, the children who were attending a follow-up clinic before the pandemic. We didn't have an exclusion criteria, and the children are admitted in the study as far as they arrived for the consultation when it started again. And we enrolled children between 18 months and 12 years old, and we had 127 children in this study. We had to stop this study in December last year because we have an increase in the pandemic in Rio. The evaluations, the programmed evaluations in this study was to look at the social structure of the families, the family structure, how they are living. For this, we use the structure questionnaire. Another evaluation was the family coping. For this, we use an instrument, brief cope, applied to the mother or the caregivers of the child. And this instrument has been already translated and validated for the Brazilian population, and it's composed of 28 questions concerning reasons and ways of the people are dealing with their stress. To evaluate behavior, use the childhood behavior checklist. The CBCL is a widely used instrument to evaluate behavior in children. It has also been translated and validated for the Brazilian population. Both brief cope and the CBCL were applied by psychologists. To evaluate motor development, I used the screening tool, and for children with cerebral palsy, we use the gross motor function classification system. And this is a widespread classification system for disabilities in children in person with cerebral palsy. All the children underwent clinical examination and had anthropometric measures done. This is a characteristic of our sample. As these are children who were former patients for any ICU, the majority of them was born by a cesarean section. As the Brazilian population, the most predominant race was non-white, of course, and we had an equal distribution of gender in this population. We had 26% of children born term born, and we had the majority of these children in the sample were preterm born. Among the preterm, we had 18% of them were born below 28 gestation week. We had 35% born between 33 to 29 to 33 weeks, sorry, and 20% was born between 33 to 36 weeks gestation age. We had small for gestation age children within the sample, and some of them were both preterm and small for gestational age. The most frequent morbidity in the sample in these children were hyaline membrane disease, and men underwent mechanical ventilation. The most frequent morbidities, neonatal morbidities found here was neonatal sepsis and bronchopulmonary dysplasia. We also had children with intracranial hemorrhage in the sample, and grades 3 and 4, and some children had retinopathy of prematurity. Looking at the development before the interruption of the appointments, we can see here that 1/3 of our sample, such 1.3%, had a normal development. Among the abnormals, the most frequent was language delay. 61.7% of the children had a language delay. It was followed by motor delay and behavioral disorder, cognitive delay, and coordination disorder. We had 6.3% of cerebral palsy in this sample. Regarding the therapies the children were attending before the interruption of the appointments, mainly they were on the speech therapy, followed by motor physiotherapy, occupational therapy, and psychotherapy. Now, looking at the nutritional status of this population, when they came to the consultation, the majority of them were classified as having adequate weight. We have very few with weight deficit. Only 9 children were classified as having weight deficit, and we have not so great proportion of weight excess. We had very few children classified as obesity, so we put together overweight and obesity. And looking at the education level of these families, because we have so few with weight deficit, the majority of both parents, mother and father, had completed their high school, and some even had superior degree. And looking at the income, the majority of these families have received the emergency financial help from the government. Looking at the distribution of the nutrition status through this strat, we separated the children, those below 60 months and those over 60 months. And we can see here that the majority of them, although having been classified as having adequate weight, when you look at the weight excess, we had more children less than 6 months being classified as weight excess compared to those with more than 5 years. Now, regarding the change in feeding routine, 66% of our families reported that they had made changes in the feeding routine, both in the group with adequate weight and in the excess weight. Now, which were these changes? We have here in orange a change in the meal hours, in gray, skip 1 or more meals, and in yellow, use of ready-made food, and in blue, increase in snack and soft drinks. And when you look at these two groups, both in adequate weight and excessive weight, the more frequent changes were in changes in the meal hours and increase in snack and soft drinks. Now, looking at the behavior of these children, we have here the preschoolers. So we split the population. We have the behavior of the preschool children and the behavior of the school children. The CBCL, it gives the predominance of using components for externalizing behavior and for internalizing behavior. So the children are evaluated, and we see here the results of the internalizing behavior and the results of the externalizing behavior. Here in red, we can see the whole population of preschool children. And we split this population, those from 18 months to 18 months to 36 months, here in gray, and those with more than 36 months to 5 years old in yellow. And when we look at the results of the behavior at the whole population, we can see that the children had a predominance of being classified as clinic externalizing behavior or borderline externalizing behavior, more compared with those having a predominance of internalizing behavior. But when we split this population, you can see here that the children between 18 months to 36 months, they still have a greater proportion of being classified as clinical internalized and behavior, borderline internalized and behavior, compared with the internalized and behavior, which was predominant. But when you look at the children with 3 years to 5 years, we find that we had a greater proportion of children, these children being classified as having clinical internalized and behavior compared to the clinical externalized and behavior. Looking at the components of this externalized and behavior, we had predominantly attention problems. We had other problems, but here in the externalized and behavior, what the children present were more attention problems, both classified as clinical or borderline. When you look at internalized and behavior found, we can see here that we found more children with the component of emotionally react or component of withdrawal. So looking now at the children with 6 years or more, again, we have here the predominance of components, the children behaving with an externalized behavior or with internalized behavior. When you look at children with 6 years or more, and how was the results of this evaluation, the majority of them had normal, the externalized behavior is in the normal limits. So fewer had clinical borderline externalized behavior. But when you look here at these children, the results of this student concern the predominance of internalized behavior, it strikes us because we have a greater proportion of children being classified as having clinically internalized behavior, that even the proportion of children is in the normal range of internalized behavior. And the components of the internalized behavior that we found more frequently was anxious depressed. We had withdrawal, we had somatic complaints, but the more frequent was the anxious depressed. Concerning the externalized behavior, there was not really a predominance of one of the components. Now, looking at how these families were coping with this stressful situation. And as soon as they arrived to the consultation, the person who came were asked, who is the main caregiver of this child? And the majority of the families reported that the mother was the main caregiver of these families. But surprisingly, we found that 32% of this sample, the respondents said both father and mother are equally responsible for the care of these children. And this is interesting because it shows that the father are becoming more interested in the care of their children. Now, the brief coping also works with many components, this question to classify, to the strategy, to figure out the strategies the families are using to face this situation. So we have here that the majority of the families, the greater proportion of the families, or the mother-related reporting this, they are using the approach coping, a predominance of mechanism of approach coping, more frequent than avoidant coping. This is a positive reaction to a stressful situation. The avoidant coping is a negative situation. And among the components of this approach coping, we found more frequent the acceptance, the situation, planning, positive reframe, active coping, so they can rearrange to face this, to cope with the situation. When you look at the avoidant coping, most frequent the families use the component of self-distraction, followed by venting, denial, self-blame. So, but this was, some families use this, but the predominance was a very positive approach to this stressful situation. The brief cope also have questions on complementary aids to help the person to face a stressful situation. Or either they can use a humor or they can use the support of a religion. And in this sample, the families, the mother and the families found used much more the complementary age of the sex support in the religion. Now, these preliminary results were still refining the analysis and were testing some hypotheses. And the conclusions were so far is that regarding the nutrition status, the majority of these children had adequate weight, but a great proportion of preschool children were over the expected weight. The mothers of the children with both adequate and excess weight reported changes in the feeding habits, and most frequently in the routine of meal hours and increase of snacks and soft drinks consumed. Regarding behavior, looking at the preschoolers, we found a greater proportion of externalizing behavior, and both clinic and borderline, and mainly in attention problems. But those, then these are a bit different. Those with 36 to 5 years had more predominance of an internalizing behavior than those between 18 to 36 months. And in the domain of internalizing behavior, the most frequent components found were emotion reactive and withdrawal. Looking at the schoolers, the most frequent disorder was in internalizing behavior. More frequent, the predominance of internalizing behavior were more frequent than children being classified in the normal range of internalizing behavior, and mainly anxiety and depression. In the externalizing behavior, there was an uniform distribution of the components. Looking at the strategies of coping the families had taken, the approach strategy was the more frequently used by the families. This is a positive strategy. They also used the support of their religion as a complementary tool to face the situation. And the most frequent components, positive components of the approach strategy were acceptance, planning, positive reframe, and active coping. Among the components of the avoided coping and negative coping, the predominance were for self-distraction, venting, denial, and self-blame. I want to thank you for having listened to our results. I want to thank the Programa Nova Fiocruz for the financial of this result. We're still going on with this result. And most of all, I want to thank all the team from the Instituto Fernando Figueira, o Hospital Pedro Ernesto, and the Hospital Gafredini. He's gone when this result was made. Thank you very much.
Thank you, Dr. Mayo, for that wonderful presentation. And colleagues, we have come to the end of our two talks, talk number 1 and talk number 2. And we have a few minutes for some questions. So I'm going to start with a question that was shared. I think this was directed to Dr. Megan Azad, where other birth outcomes considered, e.g. congenital defects or fetal or neonatal distress during the analysis from the various countries. Dr. Azad and your team, would you like to take that question? Thanks.
Sure, thank you for the question. No, we did not consider outcomes other than preterm birth and stillbirth. We also looked at total births, which actually has been quite interesting because we're seeing seasonal effects. So that might be a question we pursue separate from the pandemic research. But we were only able to get birth rates. It would have been, as you can imagine, quite an endeavor to collect information on other outcomes as well. So unfortunately, no.
All right, thank you. The second question is directed to Dr. Mayo. And the question reads, what duration of isolation in neonatal ICU had the worst effects?
They aren't in an ICU. They are being followed for abnormals in development. They are discharged from the hospital, are being followed. That's what we were worried, because they have problems for development already, because they had been with life-threatening conditions in neonatal ICU, and they are being followed for these abnormals. So we are not looking at children inside of the ICU. Probably I didn't understand the question.
Thank you for that clarity. I'm also going to, we've got a few questions that were shared during registration, and I'm just going to be reading out the questions, and it's Dr. Mayer and Dr. Azad, you may pitch in for any question. I'm not sure who would be the best to answer, the different questions. The first question that I would want to ask is, what is the current status on maternal mental health as it affects child care? Any associations between maternal COVID infection, abortion, and of course maternal health? I hope the question is clear. I just read it verbatim.
Okay, well, the COVID-19, in fact, we don't really know how this virus affects the brain, but we are talking, I don't know, in the related to the infection of the virus. But what we are seeing that we have indirect effects because of the behavior of these children. How, if they are in Brazil, we are still with the children outside the school. We are still, the children doesn't have close contact with their classmates, with their friends. And so this can affect the mental health of these children. And I think that we are seeing part of it when we look at the behavior of these children. When you look at boys and girls more than 6 years, they're old, and they are having more predominance of internalized behavior, something is not good with them. We are going to look at these children more carefully because I don't know how much this will rest on these children. They already have a biological risk for development, and now they are having these effects of isolation or the fear, because they feel fear as well.
All right.
And I don't know if this is from the virus.
Okay, thank you, Dr. Mayer. Dr. Azad, do you want to say something? Do you want to add on?
So this isn't something we've been addressing in the iPOP study, but I did want to mention there were two great questions in the Q&A that we answered in written format, but maybe Clara or Dave would like to comment on them. The first one was about representation of data, which we do think is a really important consideration and is the reason that we wanted to get national data capturing the entire set of the country. So Clara answered that one, and maybe I'll ask Dave to comment on the last one because I think it's really relevant to global research.
Thanks, Megan. Yeah, the question was really, how do we keep going across such a wide variety of disciplines, and you know, in the face of an unfolding pandemic, I think everyone's really stretched at the moment. So I think that's a really good question, and as I put in the chat, I think we realized very early on we were intrigued by those single center, single country data suggesting that there might have been a really dramatic fall off in preterm birth initially, you know, over 90% for some subgroups of preterm birth from Denmark, similarly sort of very striking data from Ireland. But we realized early on that in order to address this comprehensively and to say whether this was a real issue, we had to look at a global level. It was really important to look across high and middle and low income settings. It was important to address regional variation. That's kind of, I think we all believed in the research question. That really helped, and we all knew that there had to be a collaborative approach. We couldn't do this on our own. I think the group, we've got a natural collaborators, and I think it's really helped that we actually all still like each other. I think that's, I wouldn't underestimate that in the slightest. This is, you know, you're never going to be funded adequately. There's a huge amount of in-kind, out-of-hours work on this. So I think it's, those are the two things I'd take away, I guess, or three things. The guiding principle, so you're all on the same page, believe in the question, be respectful and like each other, and be inclusive.
Right, thank you, Dr. Begna. I'd like to invite Dr. Kofi Amega. I'm sure he wants to add on. Dr. Kofi, go ahead.
Yeah, I think as an addendum to Dave's, there is a question here which I think I want to answer and tie it up to that. Quality data is very difficult and comes with an opportunity cost. How can LMC countries balance data collection with clinical needs? I think I have already indicated that in my submission. Just to reiterate the point, Yes, clinical needs is very important. I mean, we have children coming to the hospital, we have mothers who are delivering babies, and we need to make sure that the health services are strengthened to take care of all these things. But again, we also need to be mindful of the fact that investment in healthcare, strengthening the health system, also has to be informed by data. So that is the more reason why government also need to invest in trying to have quality data. And again, the data can be accessible to researchers so that we can analyze them and have the relevant evidence to inform policy. And that will also continue to trigger more investment into trying to improve the health system and address the clinical needs, as well as also having quality data at all times. So it's more or less a vicious cycle or a ripple effect, if that is what you want to put it. And I think, as I also indicated earlier on, it's very refreshing that this is truly a global study. I mean, I'm part of some global networks, and often you hear the word global collaboration or whatever, and you realize that it's not global indeed. We also had the same thinking here. I mean, was the pandemic really impacting perinatal health? But the opportunities to investigate it was not there. So, I mean, some of us in low and middle income countries being able to collaborate on this initiative is very refreshing, and I'm sure it will generate some evidence to guide future pandemic preparedness in countries like ours and similar ones. Yeah. So that's what I want to add up. Yeah.
Okay, thank you, Dr. Amega. Colleagues, in the interest of time, I would like to ask a very last question, which was shared by our pre-registrants. And this one is directed to Dr. Assad and team. And I think it will be very important to other colleagues as well on the call. The question goes like, how do we break the silos, bureaucracy, and walls built around data sharing from national partners to international partners? Over to you, Dr. Assad and team.
Oh, that's a huge and important question. I think maybe I'll ask Clara to comment on that. She's been more closely involved in the data sharing. Clara, did you want to comment on those issues?
Trying to think, it is a big question that probably needs a lot of time to think through. I mean, I think this project, iPOP, has been amazing, and the structures that have been put in place in terms of having data contributor agreements and everything in place to upload, but it hasn't been all smooth sailing all the time, and there have been some complexities in sharing data and how we manage that. But yeah, in terms of the future, I'm not sure what I'd recommend.
I mean, one of the things, so it was helpful, as we mentioned, to have, templates, everything in the same format, have people available, like text ready to copy and paste into ethics submissions. But I think in iPOP and more broadly during the pandemic, one takeaway faster than it seemed possible before, and it's relative because it still took months, but I know in pre-pandemic studies, those things could take years. So I know just in my own institution, the process for getting approvals has been really accelerated because of the pandemic. And I hope now that we've shown it is possible, it can become kind of the new norm, because it's really important to be able to access these data in a timely manner for them to be able to inform in real time healthcare systems and policy. So that's one thing, but it has been difficult because different institutions in different countries have different rules. I think Kofi might want to have more to add.
Yeah, maybe I want to add something little from an LMIC perspective. In fact, that is one of the main challenges that we had here in trying to access data. The bureaucracies, you have to go through various processes. But what I realized was that if you indicate the public health benefits of the endeavor of whatever you are doing, it makes it easier, because you realize that increasingly these people are in the facilities, they want to improve lives, they want to protect health. So if they are well informed about the benefits of the project and of the fact that there's going to be some ripple effect, they easily want to share, they easily want to assist. So for us, that has been the approach that we have used to assess the data. And then again, it boils down to the same thing about sharing data on this initiative. I mean, transparency is very key. I mean, what does LMC countries stands to benefit from this project? So it makes it easier for us to assess the data and then also share with the initiative. So I think that is the perspective from low and middle income countries.
Yeah.
All right. All right, thank you very much, colleagues. I think, yeah, that's a broad question. In fact, it can be a thesis in itself, and I appreciate, the effort and your contributions to it. So thank you very much. In the interest of time, colleagues, we've come to the end of our presentations and our webinar, and I would like to hand over to Adam from the Global Health Network, who's been coordinating this. I want to thank you for all your participation. I want to thank you for all your contributions, and we look forward to future collaborations.